Hello, my name is Bailey Lancashire, and I am a PGY1 pharmacy resident at Abbott Northwestern Hospital in Minneapolis. Today, I'll be presenting on my major project, which is titled Cefadroxil Use in Urinary Tract Infections. I'd like to recognize my project preceptors, were Emily Herstein, Delaney Hart, and Krista Gens. The objective of this project is to determine if cefadroxil is equivalent to cephalexin when treating cefazolin-sensitive, uncomplicated UTIs. We know that first generation cephalosporins have traditionally been considered alternative options for the treatment of UTIs in our guidelines, though they are an attractive option for infections caused by susceptible Enterobacteriaceae because of their narrow spectrum of coverage and high urinary concentration. The microbial spectrum of uncomplicated cystitis and pyelonephritis consists mainly of E. coli, with occasional other species such as Proteus mirabilis, Kleb pneumoniae, and Staphylococcus saprophyticus. Cefadroxil is a first-generation cephalosporin with a high bioavailability, around 85%, demonstrates low protein binding, and achieves high urinary excretion, making it an ideal option for UTIs. Cephalexin is also a first-generation cephalosporin, demonstrating very similar pharmacokinetics to cefadroxil and is commonly used when treating UTIs. In 2014, the CLSI introduced what's known as a cefazolin surrogate testing, which infers susceptibility of 7 cephalosporins, including cefaclor, cefdinir, cefpodoxime, cefprozil, cefuroxime, cephalexin, and loracarbof when treating uncomplicated UTIs. Note that this does not include cefadroxil. Data has demonstrated that a cefazolin MIC of less than or equal to 16 is an excellent predictor of susceptibility to these agents when testing E. coli, Kleb pneumo, and Proteus mirabilis. On the bottom left corner, you'll see an example of a positive urine culture. You'll see that this cefazolin test is notated as the cefazolin UC on the culture. When applying the cefazolin breakpoint of less than or equal to 16, it predicts cefadroxil susceptibility with an accuracy of 91.6% compared with cephalexin, which is 97%. Cefadroxil is FDA approved for the treatment of UTIs caused by E. coli, Kleb pneumoniae, and Proteus mirabilis. However, as previously noted, we cannot apply the cefazolin UC susceptibility with this agent. There's not an MIC or distillation breakpoint included in the cefadroxil webpage on the FDA STIC website. Although it had been previously notated as such, the FDA has since removed any verbiage indicating that the susceptibility of Enterobacteriaceae to cefadroxil may be deduced from cefazolin testing, noting that it should not be included within the cefadroxil FDA STIC webpage. These are our IDSA guidelines, and you'll note that Bactrim, nitrofurantoin, and fosfomycin are noted as first-line agents. Trimethoprim sulfamethoxazole or Bactrim. We worry about the rate of resistance across Allina Health, with greater than 20% resistance across our metro hospitals and nearing 20% resistance across regional sites and in the outpatient setting in 2023. Nitrofurantoin has limited use due to inclusion on the Beers criteria and risk for accumulation and renal dysfunction. Fosfomycin is noted to have inferior efficacy compared to short course regimens. Fluoroquinolones are noted as an alternative agent, though impose a risk for collateral damage, notably C. diff, multi-drug resistance, and many adverse effects. Beta-lactams, also an alternative agent, have noted to have inferior efficacy. First-generation cephalosporins are included in these guidelines for cystitis as well as uncomplicated pyelonephritis. They're also referenced in our Allina Health Outpatient and ED Antibiotic Reference Guide, with cephalexin indicated for cystitis as well as pyelonephritis, and cefadroxil for complicated cystitis and pyelonephritis. And in an additional systematic literature review across 7 randomized clinical trials of first-generation cephalosporins for the treatment of uncomplicated UTIs, it did not identify a statistically significant difference when compared to other antimicrobials for outcomes of clinical care, length of hospital stay, and reinfection. IDSA guidelines recognize that narrow-spectrum cephalosporins are often used for UTIs and may actually result in less collateral damage compared with broad-spectrum cephalosporins, and include that there is a lack of adequately powered studies to make specific recommendations for these agents. So, given that the implications of the guideline-directed pharmacotherapies that are recognized by IDSA guidelines and data demonstrating efficacy of cephalosporins, additional consideration should be made to recommend them as treatment options. Most notably, more data is needed to confirm the clinical efficacy of cefadroxil when used for uncomplicated UTIs, given that the urinary cefazolin susceptibility cannot be conferred. An evaluation of treatment failure of cefadroxil as compared to cephalexin is an appropriate way to confirm if these agents are equivalent when treating uncomplicated UTIs, which was the objective of this project. For our study design, we utilized a retrospective chart review of adult patients at least 18 years of age who were discharged from an Allina Health Emergency Department between November 1st, 2019 and November 1st, 2024, with an ICD-10 code for UTI, cystitis without hematuria, and a corresponding prescription for cefadroxil or cephalexin, and demonstrating a urine culture of cefazolin sensitivity. Those with pyelonephritis, fungal UTI, bacteremia, multiple infectious diagnoses, UTI or received antibiotics within the past 2 weeks, more than one antibiotic prescription at discharge, had a polymicrobial urine culture, or if they received IV or IM antibiotics outside of the initial encounter were excluded. The primary endpoint looked at the rate of treatment failure within 7 days of discharge from the emergency department. We defined treatment failure as the return to the emergency department for UTI or if they required antibiotic switching. The secondary endpoint looked at the rate of treatment failure at 14 days after discharge and a subgroup analysis of treatment failure at 7 and 14 days after discharge in subgroups of uncomplicated and complicated UTIs. This data is largely collected via the help of our informatics team, most notably our informatics pharmacists within Allina Health. Our N was 398 patients, and we estimated less than or equal 10% difference between the treatment groups, and this was calculated using 80% power. Data that was also collected is sex, diabetes, UTI classification, pregnancy status, beta-lactam allergy, whether or not they received IV or IM antibiotics, duration of therapy, and then whether or not they received appropriate dose duration of antimicrobial, which was defined based off of our Allina Health Adult Outpatient and ED Antibiotic Reference Guide, as well as the organism that was isolated from the urine culture. Currently, data collection for this project is currently pending and in process. Here are all of my references included in this project. Thank you for your time.